Am I audible? So I hope I'm audible to all. Okay, so can I start? Just a second. Okay, so let's start with today's topic. So Farhana, Gavri, Nia, so I'm happy that you are here for the live session. Uh, yeah, so let's not waste any more time. So today's topic of discussion is gingiva and tooth supporting structures. So this forms a basis of perio, as you all know. Okay, we'll be discussing the basic periodontal structures, and it is dependent on how well you know about these structures that you can carry forward with your learning in perio, right? So to begin with, like as you all know, okay, what are the structures? what are the supporting structure, the tooth supporting structures? You have two soft tissues and two hard tissues when we say specifically. Okay, right? We have gingiva and the periodontal ligament, as well as alveolar bone and the cementum. So in this session, we'll be discussing about each of it, relevant from the NEET preparation point of view. So today, to begin with, we'll start with the gingiva, because a lot of questions have been asking from gingiva from time to time. So I think that relevance of the topic cannot be said enough. So let us first discuss about gingiva. So before moving on to the gingiva, the topic as such, like, I want you to know about oral mucosa in general. We all know that our oral cavity is lined by oral mucosa, and that oral mucosa itself can be divided into different types of mucosa. Okay. Specifically, three types: masticatory mucosa, specialized mucosa, and finally, you have the lining mucosa, right? So, what is meant by each of it? Masticatory mucosa is that type of mucosa which is subjected to all kinds of stress and friction forces from mastication and, chewing and all that. So, we have our gingiva as a part of the masticatory mucosa. And then you have the specialized mucosa, where we call it specialized because they have specialized taste buds on it, which is the dorsum of the tongue, from which you can, feel the taste sensation. And then the third type of mucosa is the lining mucosa. Whatever mucosa that lines the oral cavity other than these two, that is masticatory and specialized, will be coming in the lining mucosa, the alveolar mucosa and all, and the vestibular region and the buccal mucosa, everything comes in the lining mucosa. So these are the three types of oral mucosa, and our gingiva, okay, it comes as a part of masticatory mucosa because it is the one that is subjected to most of the masticatory forces. So by definition, it is that part of masticatory oral mucosa which covers the alveolar process of the jaws and the neck of the teeth. So that is the definition of gingiva. So histologically or microscopically, when viewed, this gingiva has got two parts mainly. That is an epithelial part as well as a connective tissue part. Okay. So this epithelial part, you can see from here, you can see from the picture that is being, just a second. Yeah. So here you can see the epithelial part, and then there is an underlying connective tissue part. And these long finger-like projections are the retipex. Okay, the epithelial retipex, which projects into the connective tissue. So, yeah. So this is the brief idea about what is gingiva by definition, by histological feature. So when we study about gingiva, we should be thorough with the macroscopic features as well as the microscopic features. Okay, questions have been asking from both of it. Okay, so when we say about macroscopic features, how does gingiva appear to us, and what are the parts of gingiva when we see it from, with our naked eye, clinically, when we see. So what are the three parts? Mainly, parts of gingiva, it can be divided into three parts mainly. That is marginal gingiva, attached gingiva, and interdental papilla. So these are the three main parts of gingiva, and you have various other sub parts which may be demarcate each of these parts. Okay, we'll see one by one in detail. So this is the marginal gingiva. We'll see each of it in detail. The marginal gingiva, which is free, which is unattached. Okay, that is what is called as a marginal gingiva, which surrounds the neck of the tooth. Okay, that is the portion which we call as a marginal gingiva. So this is free and unattached, and so you can separate it from the tooth with the help of a periodontal probe. When we insert a probe, you can easily separate this marginal gingiva. That is why it is called as a free gingiva. And then you have the attached gingiva, which is very firmly bound to the underlying bone or underlying periosteum. Okay. And this attached gingiva, it is very firm and resilient because of its firm adherence to the underlying bone, as well as the collagenous connective tissue that is present in that region. And then you have the this marginal gingiva and attached gingiva separated by a free gingival groove. Okay, this free gingival groove is a linear depression actually that is seen at the bottom of actually the marginal gingiva, but it is not clinically that evident. At least in 50% of the patients or the cases, you will not be able to appreciate it clinically. But however, this marginal gingiva, then at the bottom of it, you have a shallow linear depression which demarcates the marginal gingiva from the firmly bound attached gingiva. So you have learned about a anatomical landmark which separates the free marginal gingiva from the attached gingiva here. And the third part of gingiva was the interdental papilla here, interdental gingiva. So that is that portion of gingiva that fills up the embrasure spaces, right? What are the embrasure spaces? They are the triangular spaces which are seen when between the two tooth surfaces that approximate each other. So any gingival tissue that fills up the triangular space, it is called as the interdental gingiva. So we'll see each of it in detail. So in the marginal gingiva, all what you need to know is that it is free and unattached. Okay. And its width is 1 millimeter. It is 1 millimeter in width, and it is coronally, it extends, okay, from the CEJ over to the enamel by about 2 to 3 mm. I mean, or 1.5 to 2 mm. That is, it usually gives us that probing depth, right? The gingival sulcular depth. So this marginal gingiva, it forms a soft tissue wall of the gingival sulcus. Okay. That is the significance of it. It forms a soft tissue wall of the gingival sulcus, and this question has been asked. Okay. So you have to know this marginal gingiva is the one that forms the soft tissue wall of the gingival sulcus. I'm repeating it again. So, and then that is all what you need to know about the marginal gingiva. And now moving on to the attached gingiva. So attached gingiva, I've already told it is that portion of gingiva firmly bound to the tooth structure, and it is firm and resilient. Why it is firm and resilient? Because of its close adherence with the bone and the collagenous nature of connective tissue. And you should also know the extension of attached gingiva. It is, superiorly, it is continuous with the marginal gingiva, which is demarcated by a free gingival groove, which is a shallow linear depression, which also I have told you. And then inferiorly, it is continuous with the loose and movable alveolar mucosa. Okay. And it is demarcated from the alveolar mucosa by another landmark, which is a very important landmark, which is mucogingival junction. And this is the junction between the attached gingiva and alveolar mucosa. And this mucogingival junction, the most important feature of it is that this landmark is stationary. This is a stationary landmark, which does not change with age or whatever that happens around. So this is a very stationary landmark, and it is depending on this landmark that and the width of attached gingiva is determined, and it is depending on the width of attached gingiva that we determine if we have to proceed with a mucogingival surgery or not, or the significance of attached gingiva clinically is that the width of attached gingiva is what helps us in determining if there is a need for a mucogingival surgery or not. So that is about its extension. And then we have seen about the mucogingival junction also. And now the third part, interdental gingiva, which is the interdental papilla. So that I've already told you, it is that portion of gingiva which fills up the embrasure spaces. So the shape of the interdental gingiva, usually it is pyramidal, but then, or the triangular in shape, but it depends greatly on 3 or 4 factors. Basically, the surfaces of approximating tooth or the contacts which is formed by 2 teeth adjacent to each other. It is depending on that the shape of the interdental gingiva would be there. Because if in case of a diastema, when there is no contact, this interdental gingiva would be absent over there. So it is depending on the contact relationship between the two adjacent teeth that the shape and width and everything depends on. And then also, of course, the course of CEJ and recession. Okay. If there is recession also, this would be not present. So these are the things that on which the shape of interdental gingiva is dependent on. Now you have another important part in gingiva, which is the gingival sulcus. You all know it is a shallow V-shaped crevice, right? Which has okay. So this is the gingival sulcus, the shallow V-shaped crevice, which has tooth, which is bounded by tooth on one side and this gingival soft tissue on the other side. So what forms the soft tissue wall? It is the marginal gingiva, the inner aspect of the marginal gingiva that forms the soft tissue wall of the gingival sulcus. And this can be, this is formed by the apical migration of junctional epithelium. And clinically, you can determine its depth by inserting a periodontal probe. Okay, that is a metallic calibrated probe. By inserting that periodontal probe and by measuring the distance the probe penetrates, we can determine the depth of the sulcus. Okay, and the clinical significance is that when the depth goes beyond a certain measurement, we call it as a pocket. We call it as a diseased condition. Okay, so clinically, when we insert the probe and we insert it with a force, and then when we take the measurement, it is called as a clinical probing depth. However, that is different from histologic probing depth. So when you say about the probing depth, you have to know about two probing depths. There is a clinical probing depth as well as there is a histologic probing depth. If you ask me, the more accurate one would be histologic probing depth. Why? Because, it is actually not dependent on the force with which we probe or the diameter of the probe and all that. Okay, it is a fixed value. You can see, it is the measurement from the gingival margin to the junctional epithelium. So we take a slice of it and then we stain it and view it under the microscope histologically and we take the measurement. And it was, on an average, it was found to be 1.8 millimeter on an average. Whereas the clinical probing depth, actually in ideal condition where it is supposed to be 0 mm because there should not be any probing depth. That is what is said. But that ideal condition doesn't exist. Okay, everybody is have some sort of normal probing depth, we say, is about 2 to 3 millimeters. And that depends on, various factors. And it can change from, the clinician, the force with which we probe and the diameter of the probe and things like that. But it is generally considered to be 2 to 3 mm. So this is considered to be a normal probing depth. Okay, anything beyond this would be considered as a kind of diseased condition. Okay. So this is about the macroscopic features or the parts of gingiva. So I've already told you about the mucogingival junction. So clinically, to observe it, you can see there is a well-defined demarcating, right? The attached gingiva and the mucogingival, the alveolar mucosa. And this line, which is stationary throughout life, is called as a mucogingival junction. Certain points, I'll be repeating it again and again so that it will be there in your mind. It will stuck in your mind. Okay. So now we'll see about the significance of each of it. The first, about the significance of attached gingiva, I've already told you. It is based on, because, attached gingiva, it is that firm and adherent portion of gingiva, firmly bound to the underlying, alveolar bone or the periosteum, right? So that its width is very important. If there is an insufficient width of attached gingiva, then it means that there is the patient or the person is more prone to periodontal breakdown or gingival recession. And it is because it's difficult to maintain even oral hygiene for such patients. So the need for mucogingival surgeries are dependent on the width of attached gingiva. So that is one of the important. And when you say about the attached gingiva, when you see the measurement for attached gingiva, or the width of attached gingiva, you should not get confused with keratinized gingiva. Okay, because if you say about keratinized gingiva, the whole of gingiva, that is from the crest of the margin, that is marginal gingiva with the attached gingiva, everything is keratinized. Okay, but attached gingiva is only that portion which is firmly bound. It does not include the marginal gingiva. So the keratinized gingiva is different from attached gingiva. So here in this picture, you can see a black line, right? So this is attached gingiva, whereas ahead of it, there is about over 1 to 2 mm or 1 mm marginal gingiva which is present. So the keratinized gingiva also includes a marginal gingiva, whereas attached gingiva does not include marginal gingiva, but it is a keratinized gingiva. I hope you understood. Okay. So the main thing is that only thing you have to remember, keratinized gingiva is different from attached gingiva in terms that keratinized gingiva also includes the marginal gingiva. Okay, so the width of attached gingiva, you should know the width of attached gingiva, and it varies from person to person as well as location to location. Okay, so it is seen maximum in the maxillary anterior region, and with least width seen in the premolar region, that too mandibular premolar region. So you have to know these values. You'll have to write it somewhere. I highly recommend all these values to be written on a sticky note and stick it somewhere you see regularly, so that you will, it will you will get retained. All of these values will be retained in your mind. Okay. So with the maxilla, you have incisors. That is a maximum width of attached gingiva that could be seen 3.5 to 4.5 mm. Whereas in mandible, the incisor region, it is 3.3 to 3.9 mm. And the least width is seen in the premolar region. Okay, maxillary premolar region, 1.9 mm. And mandibular premolar region, it is almost 1.8 mm. So these are the values. Okay, so until now, what all values we have seen? We have seen that the marginal gingiva, we have a width of 1 mm. And then it extends from the CEJ coronally to the enamel by about 1.5 to 2 mm. And then we have seen the histologic depth and the biologic depth. Or biologic depth as well as the clinical probing depth. The clinical probing depth is generally 2 to 3 mm, whereas the histologic depth or biologic depth on an average is 1.8 mm. And now we have seen the width of attached gingiva. Okay, all these values you should have it in your mind. Okay, direct questions can be asked from that. So now with relation to, I've already told you about the attached gingiva, its clinical significance, its function and everything. Okay, it's very important that you have adequate attached gingiva to maintain your oral hygiene and also to prevent any type of periodontal breakdown. That lies the importance of it. So we have to know how to measure the width of attached gingiva. You can measure the width of attached gingiva purely by a visual method. Just by observing certain areas, clearly you can see in the picture I've shown before, you can see that line of demarcation, the mucogingival junction very clearly, right? So such areas you can just by looking, and if that portion have adequate width, you can just determine, okay, patient has adequate width. That is a simple visual method. And another visual method is by histologic staining, where you use iodine solution, Lugol's iodine or Schiller's iodine. So a point to be remembered here is that when you when you use this iodine to stain, we stain actually the keratinized gingiva. We stain actually the alveolar mucosa, not the keratinized gingiva. So we usually have a thinking, okay, we observe attached gingiva by histologic staining. So the attached gingiva will get stained. It's not like that. Okay. It is the attached gingiva will not get stained, but the alveolar mucosa will get stained. Okay. Why? Because this keratinized gingiva, it doesn't contain glycogen. And this Lugol's iodine or Schiller's iodine, this iodine solutions, they stain the glycogen which is present in the alveolar mucosa. So it is the alveolar mucosa which gets stained in the histologic staining with iodine solution. And then finally, you have the clinical method, okay, where you can measure with the periodontal probe as well as a tension test, which I will be discussing. So here you can see this is a normal gingiva. You can simply by visualizing it, you can determine if this is, if the attached gingiva is adequate. See, you can have a clear demarcating line between the attached gingiva and alveolar mucosa. And then this is histologic staining. See here the brownish iodine pink color. Okay, that has stained the alveolar mucosa, not the keratinized gingiva. Okay, it stains the alveolar mucosa because it has glycogen content in it, and it is what gets stained. It is what absorbs the iodine and produces its color. So the alveolar mucosa has got stained. And then you the clinical method by which you can use a periodontal probe and calculate the width of attached gingiva. While calculating, first you need to identify the mucogingival junction. And once it is identified, from the crest of the margin to the mucogingival junction, you have to take a measurement and then subtract the probing depth, okay, from that measurement. So that will give you the width of attached gingiva. Then you have the tension test also. If to know if the width of attached gingiva is inadequate, that is simply stretch your lips and cheek. Okay, so that if the width of attached gingiva is not adequate, if when you stretch it like this, it moves the marginal gingiva will move, and that by that because of the tension it produces because of the muscle pull. So that shows that attached gingiva is not adequate. So that is a simple tension test clinically, which you can practice to see if the attached gingiva is not adequate or not. So, and we say that minimum 2 mm should be there for a healthy periodontium. Okay, so if it is less than that, then we'll have to consider the mucogingival surgical procedure. So I hope that is clear to you. Now, next important part is the interdental gingiva. In the interdental papilla, we have another significant part called as the cold, okay, or the interdental gingival portion. So this fold is a feature which is generally seen in the posterior teeth, mainly because I told you it depends. The interdental papilla, its shape and its form, everything depends on the two tooth surfaces approximating each other. So in the anteriors, it is generally, point contact between two teeth that's approximating. Whereas in posterior, it is more like a surface contact. So that forms a valley-like depression here. Okay, so this is from the side, but this is a view from the side, and you have this facial papilla and the lingual papilla, and the point of confluence of this facial papilla and the lingual papilla, you have a valley-like depression, which is termed as coal. The significance of coal is that it is non-keratinized. Okay, and also this is the site which harbors maximum microorganisms, and it is easily periodontal breakdown starts from there. Okay, because of its valley-like depression where food can go in and stuck there, as well as it is non-keratinized, and it starts up the inflammation process altogether faster. Okay, so this is the significance of coal. So coal can be pyramidal or as well as this valley-like depression, because see in the figure A, it is anterior teeth and the contact is kind of point contact, so it is more like a pyramidal shape. Whereas in posterior teeth, it will give this valley-like depression, which is called as a coal. And in recession areas, this coal is absent. Okay. So that is this figure. This is all figures from your Carenza, which you need to know because questions, have been asking from image-based questions now. So you should just be familiar with all the figures. Now, next is about the gingival sulcus significance. Okay, we have seen what a gingival sulcus is. So we have to know how it is, what significance it has. This is a V-shaped crevice, right? The significance of gingival sulcus is mainly with relation to the fluid that is present in the sulcus. That is gingival crevicular fluid or sulcular fluid, which we'll see in detail in the next subsequent session. But you have to know this fluid has got various functions. Okay, that it cleanses the gingival sulcus, sulcular area. Then it has various contents which has antimicrobial properties, and so it fights against any infections and bacteria that comes, and then also has antibody activity that defend the gingiva. Then finally, and most importantly, it has got plasma proteins, okay, that improve the adhesion of the epithelium, the gingival epithelium, onto the tooth surface. So these are the four main functions of gingival sulcus. It cleanses the area, it helps in attachment to the tooth surface for the epithelium by giving the plasma proteins, and has got antibody and antimicrobial activity. So that is the significance of gingival sulcus. And with that, the major parts of gingiva is being covered. Now you will have to know about the clinical features of a healthy gingiva. Only if you know how a healthy gingiva appears to you, then we'll understand how the abnormality, when an abnormality comes, right? We have to know how a normal thing appears if we have to diagnose an abnormal condition. So it is important. So we'll be discussing briefly about, from the exam point of view, about the color, size, contour, most importantly, surface texture, then position and shape and all that. So beginning with the color, you all might be knowing, we all by heart it is coral pink in color. But you have to know, why is it coral pink and what are the factors that determine the color of the gingiva? There are basically four factors. What are the four factors? The, thickness of epithelium, the degree of keratinization, then underlying vascularity, and then the physiologic pigmentations. So these are the four factors that determine the color of gingiva. So, due to exactly the same reason, okay, when the color of attached or marginal gingiva is coral pink in a normal healthy state, whereas the color of alveolar mucosa is slightly to the brighter red side. Why? Because it is not keratinized, first of all. So it depends on the color of the lining, the oral mucosa itself, dependent on the epithelial thickness and the degree of keratinization and underlying vascularity mainly. So in the alveolar mucosa, the epithelium is thinner, there is no degree of keratinization and highly vascular, and so it appears more brighter red in color. Okay. Whereas in the gingiva, there is some amount of keratinization, some amount of thick epithelium, stratified squamous epithelium that is present. And also you have the underlying vascularity, but this epithelial thickness and the degree of keratinization mask this vascularity to some extent, giving it a coral pink color. And the physiologic pigmentations also play an important role. For example, the melanin pigments. In persons who have high degree of melanin pigments, it will appear slightly on the brownish, blackish color. Okay. And but you will have to know about various other types of pigmentation that can be seen in oral mucosa also, because questions have come from there. That is, anything which I have marked in green or yellow is where questions have come from. So here this is, so when we say about pigmentations of oral mucosa, you have endogenous pigments as well as exogenous pigments. Endogenous pigments are the pigments that are produced from our body itself, within the body, because of certain physical conditions or physiologically normally produced. And then there are exogenous pigments, which are which come from external factors. So how I remember it is, melanin, it is brown, black in color. And bilirubin also, it is yellow in color. And hemosiderin is iron, iron, okay. And hemoglobin is also iron related, but when you test your blood, we check the hemoglobin, right? So the blood, when we take, what all colors it exhibit usually? Red, bluish, purple, and all that. So for hemoglobin, endogenous pigments, when it is present, it is the same color, purple, blue, red color. While hemoglobin is purely iron, and that is brown in color. The way by which you can remember it, okay? Otherwise you will get confused, no? So, and similarly with relation to exogenous pigments also, for the chromogenic bacteria, you might have seen clinically that black or green or brown, small spots that is seen on the tooth surface. It is because of chromogenic bacteria. Then the lead and the graphite, it gives more like a gray line. Okay. How do you remember and how do you, retain it from the other exogenous pigments? How I remember is, our pencil, which has a graphite road, right? Or the lead road. When we pencil it is gray in color. So similarly, I retain it like that. Okay, they give a grayish line along the marginal gingiva. And silver amalgam is nothing but the mercury. And this mercury, bismuth, and arsenic balm. Okay, so that is black. That gives a black color. How I used to remember was this. There was a this bismuth, arsenic, mercury. It's balm. Okay, balm. There was a balm during when I was child and all. I don't know if it still exists. The something called as iodex balm or something. So that was black in color. So that's how I remember the balm. It gives a black exogenous pigments. So these are the different types of pigmentations that you can see in the oral mucosa. Now, in the case of chronic inflammatory condition, this coral pink changes to reddish or bluish in color because of the same reasons which I've told you. Okay. Because the vascularity, it increases, inflammation, it increases, and bluish hue when there is a venous stasis. So it is the same thing. Okay. And now the size, the only question that has been asked on size is regarding the definition. Okay, the sum total, you should know what the size means. Okay, it is a sum total of the cellular and intercellular components and their vascular supply of the gingiva. Okay, that is what is meant by the size. And then the contour. Contour is this shape. Okay, usually this is knife edged, scalloped, purely scalloped. But again, this depends on the approximating tooth surfaces or the shape and size and alignment of the tooth in the arch or the teeth in the arch, the contour. And this thing, there are sometimes we can see the changes in the contour depending on the alignment of teeth in the arch. And there are two other conditions which exhibit a change in the contour. What are the two conditions? Of course, in gingival inflammation, you can see a change, but otherwise, in McCall's festoons and Stillman's cleft, you should know what is what. Okay, these are the conditions which show a change in the contour. These are actually kind of lifesaver type changes that happen to the gingival contour. When we say lifesaver, because it exhibit as like a change in response to some force or unnecessary external factor. Okay, as a defense mechanism. So clinically, this will be like this. This McCall's festoons are like this. Lifesaver shaped gingival enlargement around certain teeth. So generalized, it would be not present that in a generalized pattern. Usually in a localized area or related to one or two teeth, it will be present. And this is it. The lifesaver shaped enlargement which surrounds the neck of the teeth with some amount of precision. And this is the McCall's festoons. And the Stillman's cleft, a cleft which is seen in the gingival margin. And the exact cause of this conditions are not yet clear, but we attribute trauma from occlusion as a cause for it to some extent. Okay. Then the consistency we have already covered. It's firm and resilient because of the collagenous nature as well as firm adherence to the underlying bone. And then you have the most important, and n number of questions have been asked from this stippling. Okay, stippling is actually an orange peel-like appearance, which is seen in certain parts of gingiva. So which parts of gingiva, it is important. Why it is seen also, it is important. Okay, so which parts of gingiva show stippling? It is wholly related to attached gingiva in a healthy periodontal condition, and also the core of interdental papilla, not the whole of interdental papilla. It is only the core of interdental papilla. So the core of interdental papilla and attached gingiva shows this adaptive specialization called as stippling. Okay, which is an orange periodontal or a healthy gingival state. You can see this. And how do you see this? Okay, clinically, if it is not visible, then you can try visualizing it in the light by drying the gingiva with a cotton or a, cotton, it is being used. So that is how you visualize it. So this is like an orange peel appearance, right? So marginal gingiva usually doesn't exhibit this stippling feature. Okay, and that you will have to know. And why is this stippling seen? These are like elevations and depressions. When you see it closely, they are kind of minute elevations and depressions. That is because of the retipex, the finger-like projections of retipex into the connective tissue. That is what gives this appearance. And this feature, usually it is not present when a baby is born and also at the stage of infancy. Gradually, it starts appearing and it becomes prominent at the age of 5 years. And then it is present throughout the youth and adulthood. And then when one hits their old age, it starts again disappearing. Okay. So that is a normal pattern that has been seen with stippling. So stippling is a feature. We cannot say all patients with healthy periodontium or healthy gingiva will show stippling. But if stippling is present, that is a sign of healthy gingiva. Okay. But in case of gingival disease, definitely there will be loss of stippling. So next is about the position. The last thing about the clinical feature that you need to know. So with regard to the position of gingiva, we tell the position of gingiva in terms of the marginal gingiva, what we see clinically. So the position of marginal gingiva determines the position of the whole gingiva as such, right? So it is like about 0 to 3 mm coronal to the CEJ. It is slightly above the CEJ that it is seen. And one of the interesting feature is that actually the position, it is continuously changing. Okay. Or I don't know how many of you know about the passive eruption. All of you will be knowing about the active eruption. Okay. Active eruption is that movement of the teeth towards the occlusal plane until the tooth reaches the occlusal. You will be knowing the tooth is erupting. Okay. And the tooth erupts until it reaches the occlusal plane. But in terms of passive eruption, there is yet another eruption that continues after the active eruption. What is that? The apical migration of gingiva. Okay. So that is what is called as a passive eruption. So it is because of this passive eruption, I've told you the width of gingiva, it changes with age. And mucogingival junction is a stationary landmark also. But this tooth, it continuously erupts in the oral cavity with the apical migration of the coronal marginal gingiva. So it is because of this feature that the width of gingiva changes because, superficially, it has the marginal gingiva as the landmark, and inferiorly, the landmark is mucogingival junction, which is a stationary landmark. So the changes in width of gingiva happens only because of the change in the coronal portion of the gingiva, not the inferior portion. Okay. So it is because of the passive eruption that the width also changes. And I think with that, we have covered most of the macroscopic features of gingiva. So now we have the microscopic features. So with the microscopic feature, you should know all parts of gingiva. It's stratified squamous epithelium covers it. An epithelium covers it and it's stratified squamous epithelium. Why it is stratified squamous? Squamous epitheliums are the polygonal shaped cells that are, and simple squamous has only one layer of that cells. But stratified means there are multiple layers of that polygonal cells which are stacked together. So that is what is stratified squamous. So gingiva, histopathologically or histologically, it consists of this stratified squamous epithelium and the connective tissue component. And this epithelial, it is highly cellular. You have cells, lot of cells in it. So mainly keratinocytes, which produces keratin, and also non-keratinocytes are there. What are the non-keratinocytes? Langerhans cells, melanocytes, and Merkel cells. These are the three main known keratinocytes which are present in the epithelium of gingiva. Any epithelium will have these four stratas or stratum, especially the keratinized ones, have the four stratas, right? Stratum basale, stratum spinosum, and granulosum, and corneum for especially the keratin layer. So the epithelium has got these four layers, and you should know where these each of these cells are present. Okay, that means how I remember it is, okay, you have known keratinocytes as Langerhans, melanocytes, and Merkel cells, right? In the Langerhans cells are defense cells. So they need to be available anytime this, attack comes. So they are present in the suprabasal layer. Suprabasal layer. Okay. And you have the Merkel cells, which are actually tactile receptors where, nerve endings are present and it gives a sensation. So that is present in the deeper layers of epithelium, close to the connective tissue. And then you have the melanocytes, which is spread uh, actually not very deep, but then in between. So basal and spinous layer. Okay, so that's how I remember it. Hope it would be beneficial for you also. And then you have the connective tissue part, which has primarily collagen and it's less of cellular nature. Okay, so when we speak about the microscopic feature of epithelium, we need to know about the keratinization, the degree of keratinization mainly, which is pertaining to each of these different types of epithelium. So the gingival epithelium itself can be, divided into different types, okay, based on the degree of keratinization or based on their location. First, you have the outer epithelium, which is from the gingival crest, okay, marginal crest, and the outer epithelium that is being seen, okay, till the alveolar mucosa. Then you have the sulcular epithelium, which lines the sulcus, and then you have the junctional epithelium, okay, this portion where the gingiva is attached to the tooth, okay, that is what is junctional epithelium is. So basically, you have three types of epithelium microscopically, depending on the location as well as keratinization and the microscopic features. So you should know the keratins present and all because questions have been frequently asked. So the side, I have written K1, K2, K10, 12, 6, 16, 5, 14, and 19. So these are the main keratins that have been present in, relation to this gingival epithelium. So you should know where it is being present. Okay, so for that, you have to know the functions of each of these keratins are main characteristics of these keratins. So with relation to 1, 2, 10, and 12, they are epidermal type. Epidermal is superficial skin in the ulna. So that is seen in the outer epithelium. Okay. And 6 and 16. 6 and 16 is a highly proliferative epithelia shows this keratins. So that is again, gingival epithelium is highly proliferative. So outer epithelium has 6 and 16. And then 5 and 14, it is and 19. 19 is actually it is seen in those which are partially keratinized, not fully mature keratin. So it is again seen in the outer epithelium. So actually outer epithelium consists of, and this 5 and 14 are stratified cytokeratin. So stratification, wherever the stratification is seen, that is the area where this 5 and 14 is seen. So outer epithelium has got all of these cytokeratins. Okay. Whereas sulcular epithelium, it is not keratinized. So in areas where it is not keratinized, K19 is present. Okay. So K19 is present in the junctional epithelium also because it is non-keratinized. So remember, wherever it is not fully keratinized, K19 is present. So it is present, of course, in sulcular epithelium and junctional epithelium and in outer epithelium also to some extent. Okay, even though it is mostly keratinized, there are some areas where it is not keratinized. So it is present there. And one feature that you all have to retain in your mind is that K6 and 16 is a highly proliferative epithelium, but still it is absent in junctional epithelium. In spite of the fact that junctional epithelium is highly proliferated, high turnover rate is there, but still 6 and 16 keratins are not present in junctional epithelium. That you will have to remember. Okay. So now moving on to junctional epithelium specifically. And here actually one of the this I would love to club with another important thing, that is attachment of the gingiva with that of the tooth, because many questions have been asked from that. Okay, that is, once this, what is junctional epithelium? For that, you need to know what is junctional epithelium, because gingiva is mainly attached to the tooth at that because of this epithelial attachment called as the junctional epithelium. Okay, here. So junctional epithelium is actually, so when a tooth is inside the oral cavity before erosion, this is lined by reduced enamel epithelium, and then you have the oral epithelium. Okay. So once when the tooth erupts into the oral cavity, this reduced enamel epithelium confluence with the oral epithelium, and that point of confluence we have the junctional epithelium that is formed. And this is usually initially it is 3 to 4 layer thickness, and then gradually it progresses to 10 to 20. You should also know about the length of the junctional epithelium. That is this length of the junctional epithelium here. This length, that is 0.25 to 1.35 mm. That is the length range. Okay. That also you will have to know. So, and this is a non-keratinized epithelium. So this is the figure which explains you the attachment of junctional epithelium to that of the tooth. Okay, so you know, gingiva is attached to the tooth at that because of this epithelial attachment called as a junctional epithelium. Okay, so this junctional epithelium itself, when we observe it closely, they have this external basal lamina and internal basal lamina. So this is the internal basal lamina and this is the external basal lamina. Okay, the whole of this portion is called as the junctional epithelium, and this external basal lamina is the one that connects the junctional epithelium with that of the connective tissue here. Whereas the internal basal lamina, it provides a connection with that of the tooth with the help of hemidesmosomes. That you need to know, the hemidesmosomes. Okay, so because this internal basal lamina itself has lamina densa and lamina lucida. So this is the enlarged view from this small portion of attachment. Okay, you have, this is the internal basal lamina, this whole thing, lamina densa, lucida, hemidesmosomes. This is the internal basal lamina where you have the lamina densa closer to the tooth. Then you have the lamina lucida to which the hemidesmosomes are attached. And then this hemidesmosomes are attached to this part of the basal lamina and then the other cells of the junctional epithelium. So that is how the hemidesmosomes have a very important role in the firm attachment of the gingiva with that of the tooth. So if a question comes like, okay, what gives attachment, what plays a primary role in attachment of gingiva to that of the tooth? If the answer has only epithelial attachment, it is answer. But if the answer has junctional epithelium, that is the more right answer. Okay. And if the option has hemidesmosomes, usually hemidesmosomes and junctional epithelium doesn't come together because it's all part. But if there is an option of hemidesmosomes is the answer, which gives that firm adherence of gingiva to that of the tooth. But then it is not only the junctional epithelium, but this attachment which is provided by the junctional epithelium is further reinforced by certain gingival fibers also. Okay, we have three main set of fibers, gingival fibers, which reinforces the attachment which is provided by the junctional epithelium. So together, the junctional epithelium and the gingival fibers are called as a dento-gingival unit. Okay, so what are the three fibers? We have the transseptal fibers. This transseptal fibers, you need not get confused. This is the same as the periodontal ligament fibers. We will study it in periodontal ligament fibers also, which run from tooth to tooth, but no connection with that of the bone. Okay. And horizontally they run. And also ring-like fibers are there, which are the circular group of fibers. And then the gingivo-dental group, which fan out in the labial and the facial lingual aspect. Okay, so these are the three gingival group of fibers, which gives further reinforcement to the attachment. So if the question has both junctional epithelium and dento-gingival unit, then you have to go for dento-gingival unit because dento-gingival unit has both the junctional epithelium and the gingival fibers. So that is what is more appropriate. So you will have to read the question thoroughly, the answers thoroughly, and then you have to appear for them. And this is another concept which you should know, the biologic width. So now you know the junctional epithelium, you know that gingiva has connective tissue, right? So it is actually a concept which is very important from the restorative point of view, perio-restorative side. So according to this, this is a dimension. Biologic width is a dimension which is cumulative of the junctional epithelium and the connective tissue. So altogether, it gives off a value of 2.04 mm. So the this concept lies in the fact that whenever we place a restoration, it should remain within the gingival sulcus. And if the restoration, it hits this particular region, then there are high chances of periodontal breakdown and inflammations to appear in the long term of that restoration. That is where the significance of this biologic width lies in. You need to know about the value 2.04 and what it is. Okay, it is the dimension which is cumulative of the junctional epithelium and the connective tissue. That is the dimension of soft tissue which is present, which has got its extension from the base of the junctional epithelium and until the alveolar bone or above the alveolar bone. This is what is called as the biologic width. And also you have to know about the blood supply because that also question has come. But you can think about it when the options have comes, there is supraperiosteal vessels from the PDL, and also vessels that emerges from the alveolar bone interdental septa. Okay, that supplies the gingiva. And now we'll move on. So with that, we have covered the gingiva. Now we'll quickly go through the PDL, cementum, and bone because specific questions have asked from some specific areas only. So we'll cover it up very fastly because gingiva was the most vast portion. Okay. So with regard to PDL, the main things which you need to know, what is PDL, then the components, structural and cellular components of PDL, then the theories related to it. So what is PDL? PDL is a highly vascular and a highly cellular connective tissue. Okay, that surrounds the tooth root. And, it is continuous coronally, also above, in the above portion, it is continuous with the connective tissues of the gingiva, and below it is continuous with the apical vessels. Okay, so, and then laterally, all surrounding, you have the connections, from that is the fibers as well as the vessels coming from the alveolar bone and all connecting the periodontal ligament. So, the synonyms, you need not study it by heart, but you should just know what and when. For example, the pericementum, then the periodontal membrane. All these are other synonyms of the PDL. Because if a question asks regarding pericementum, you should not think it is something related to cementum. It is periodontal ligament itself. Okay, so you just go through it. So these are the various other synonyms used for periodontal ligament. Okay, desmodon, gomphosis, pericementum, alveolo-dental ligament, and all that. So regarding the extension and shape, so we have already told superiorly it is continuous with the connective tissue or the lamina propria of the gingiva. The lamina propria is another name for the connective tissue. And then the apex, there is the apical vessels, the pulp, dental pulp. And then laterally and around the periodontal ligament, you have the alveolar crest fibers. Okay. And it generally has a hourglass appearance. Why? Because there is a point where it is narrow, almost in the middle, but actually at the junction, it is at the point where the axis of rotation of tooth happens, where the PDL is narrowest. So in a single rooted teeth, the axis of rotation is in the junction of apical and middle third. So that is where it is narrowest. Whereas in multi-rooted teeth, it is in the bone between the two roots. Okay, the axis of rotation. So it is in that furcation region where it is narrowest. So you have to know the width also. It is on an average 0.2 millimeter in width, just 0.2 millimeter in width. Its width ranges from 0.15 to 0.38. So you learned what is PDL, its extension, and then the shape, hourglass shape, and it is narrowest in the axis of rotation. And there are some other areas also where you can see a narrow PDL. What are the other conditions? Okay, when the tooth is not in that function. Okay, ഉപയോഗിക്കാതിരിക്കുമ്പം കുറയത്തില്ലേ? അപ്പൊ അത് തന്നെ it is seen in PDL. When in states of hypofunction, there is a narrow PDL that is seen. So when there is an antagonist teeth that is absent, unerupted opposing tooth, or a lost tooth, or in case of open bite, you can see that. Okay. And also when there is a tooth that is missing and when there is a mesial shift. Okay. Physiologically, tooth moves mesially, right? So in that mesial shift happens, that mesial root surface, there will be a narrowing of the PDL. And widened PDL, so it is seen just opposite to the conditions where the narrow PDL. In states of hyperfunction, when the function, the load or the stress is more, widening of PDL can be seen. Okay, in trauma from occlusion, and also these conditions which you have to by heart, scleroderma and osteosarcoma. So this is, and you can appreciate radiographically, actually, PDL periodontal ligament space, loose space, which is actually running parallel to the root surface. But it is demarcated by a radio-dense line, which is called as the lamina dura, which we'll see in the bone when we study the bone portion. Okay. So this is how the radiographic feature, when you say it is a radio-lucent space, which runs parallel to the root surface. And it is demarcated on the other side by a radio-dense lamina dura. And the lamina dura, it is radio dense because it is that portion of the bone into which the fibers of the periodontal ligament, the principal fibers, get attached and embedded, which gives that radio density. Okay. So when we come on to the structural components, it's the most important in the PDL. You know, they have, it's highly cellular and it has got extracellular components also, and it has majorly the principal fibers. Okay, they are the main constitution of the PDL. So with regard to the cells, they have all the cells, both synthetic and resorptive cells. Synthetic cells in the sense, osteoblast, fibroblast, cementoblast, all the formative cells, as well as they have the resorptive cells, clast, osteoclast, cementoclast. Fibroblast is a resorptive cell as well as a synthetic cell because it has the ability to form the cells like osteoblast and cementoblast as well as the fibers, collagen fibers, and also it degrades the collagen that is dead and decomposed. So it has all the functions. Okay. So, and it has both synthetic cells and resorptive cells and their progenitor cells. So for the cells to come, there should be some precursor cells. So they are the progenitor cells. And also this PDL has got what? Defense cells also related to it. Okay. And defense cells means the ones which fight when the disease or infection comes, like monocyte, mast cells, eosinophils and all. And also the epithelial rest of molasses, which are actually remnants of Herdwick's root sheet epithelium. When a root formation happens, the sheet, it degenerates usually, but some remnants remain. So it is also seen in the PDL. And also this has got the extracellular component, which is other than from the cells, the intercellular area, there is extracellular components, which includes the fibers and also ground substance, proteoglycans and glycoproteins. So you have these structural components. This forms a structure. So first we'll see the fibers. Principal fibers. We have 6 group of principal fibers. Okay. So all of which are made, actually all the important, I mean, all parts related to perio, that is collagen, the gingiva, bone, principal fibers of periodontal ligament, as well as the cementum. Everything has got collagen only. Okay, there is no other, it is all made of collagen, type 1 collagen. Okay, there are different types of collagen, but then it is all made of type 1 collagen only, except for the basement membrane. Basement membrane alone has type 4 collagen. There is a easy way to remember it has been given in dental pulse, floor on the floor or 4 on the floor. So that is like 4. It is basement membrane is the floor, right? So type 4 collagen is only there. That is seen in the basement membrane in relation to perio that I'm saying. But all other important structures in perio, it is from type 1 collagen. Okay. So, so you will see about the important groups, principal groups, fiber groups. Okay. Firstly, transeptal fibers, which we have already seen. And then we have other 5 set of fibers. It is easy to remember based on their course and from their attachment. Okay, next is the alveolar crust fibers, which runs from the cementum. Okay, always you take it from the tooth to the bone. Okay, you take the direction, of course, of these fibers from the tooth to the bone, and uh, the function of these fibers will be opposite to their course. Okay, I'll explain to you. You will understand it better when I explain it. That is alveolar crest fibers, from the tooth to the bone. So alveolar crest fibers, when they run, it is from the cementum to the alveolar crest. So it runs apical direction. So when it runs apical direction, it prevents the opposite extrusion forces. Okay. Prevents the tooth extrusion as well as the lateral tooth movements to some extent. So the force is apically, but it prevents the extrusion force. Horizontal fibers, they run horizontally between the alveolar crest and the cementum, number 2. Okay. But and it prevents the lateral forces. And then the oblique fibers forms a major bulk of this principal fiber group. So that almost like 2/3 of the root is being occupied by this oblique set of fibers. They run from the alveolar bone to the alveolar crest fibers from the alveolar crest. Okay, I mean, they from the tooth to the alveolar crest. Whereas oblique group of fibers, they run from the tooth cementum to the alveolar bone. Okay. And in a coronal direction. So when they run in the coronal direction, what happens? It prevents the vertical masticatory forces and intrusion. So it prevents the intrusion and vertical masticatory forces. So opposite the action is. And then you have the apical fibers and interradicular fibers. Apical fibers are the ones at the apex of the roots. And so in a tooth with no apex formed properly, this apical fibers will be absent. And interradicular fibers in the furcation area. Okay, it is same. They fan out in the furcation area. So these are the 6 group of fibers. So in the oblique group, I've already told they form the major bulk of it, major bulk of fibers. Okay. So you have to know the course. The course is in the coronal direction from the cementum to the bone. Obliquely they run. So when it is in the coronal direction, the action is they prevent the vertical masticatory forces and so prevent the intrusion of the tooth. Okay. And the sharpest fibers are the same principal fibers, but that portion of the principal fibers which are embedded in the cementum as well as alveolar. Okay. So that is what is called as the sharpest fibers. And then you have the interferent fiber plexus, which are also collagen fibers, but not that mature enough. And also there's small collagen fibers run in all directions to further reinforce this primary complex. And then you have immature fiber groups, which are elastin and reticular fibers. So this elastin examples you need to know, oxytocin and iluvanin are the 2 immature, these immature fiber groups, they run parallel to the root surface and they, they support the vascular supply. Okay, so you need to know about this 2 immature elastic fibers, that is oxytocin and iluvanin. And the cellular composition we have already seen. And in that, the fibroblast also we have seen. And now the most important part of it. And when we speak about collagen, I have already told you the main of the principal fibers, most of the fibers and the major extracellular component is made of collagen only, EDL. So, and you need to know this is arranged in bundles, the collagen. So this is at a periodicity of 64 nanometer. This has come for an exam. So you need to know this value, 64 nanometer. Okay. And this also I have seen all the components which we deal with are from type 1 collagen and only the basal lamina, it has type 4. Okay. Then you know about the function of PDL also. It is mainly that shock absorbing and it anchors the tooth within the socket. That is the major and transmits occlusive forces. So mainly it is shock absorption. And also it has got the sensory function because it has the nerve endings. And so these nerve endings are majorly, they emerge from the major nerve, trigeminal nerve, the maxillary and mandibular branches of trigeminal nerve. And they have other functions, formative, remodeling, nutritional, because of the cells. They have both synthetic and resorptive cells. So they have formative and remodeling function. Okay, and coming on to the theories associated with PDL, there are 3 theories that have been put forward in relation to PDL. First one was tensional theory, where we believe that it was completely the function of the periodontal ligament fibers that, you know, uh, the masticatory forces, and to hold the tooth in position and to bear the masticatory forces, it was completely the function of the fibers of the PDL. Okay, wherein we believe that when there was an excess load, this PDL fibers, they stretch and tense, then that causes an elastic deformation of the alveolar bone on the other side. So what happens? And once the stress is taken away, then that bone is an elastic one, so that it comes back to the original position. That was what we believed in tensional theory. But later, we came up with the viscoelastic theory, where we believed that it is not only the function of fibers, but there is an additional fluid that is present in the extracellular fibers allata bhagata. There is a fluid, and this fluid, when there is a force which is transmitted to tooth, this fluid, they pass into this narrow spaces of the bone, and when the fluid gets passed, that PDL get compressed, right? That component is not there, so it get compressed, which gives that shock absorption, and once this is taken away, it again flows back. That was what we did. But then now the latest and what we believe in is the thixotropic theory, in which we believe that PDL behaves like a thixotropic gel. Okay, wherein, thixotropic gel is the one when there is an excessive force that is applied. This gel, it becomes, when it becomes a fluid or gel-like consistency, and then once after the force is not there, it becomes semi-solid again. Okay, so when the force is there, force, it becomes more liquidish, and then after once it is being taken away, it becomes semi-solid again. So it behaves like a thixotropic gel, and that is what the thixotropic theory states about. And coming on to the blood supply of PDL, this picture will help you to remember it. So this is the PDL. So PDL has got anastomosis from the gingival area, the apical from the pulp, from the dental pulp, apical vessels, and then from the alveolar septa, the penetrating vessels from the alveolar septa. So these all things gives the innervation. And of course, they have the lymphatic, and that are not that important. But then the nerve supply, I've already told, they have got the sensory receptors and nerve endings, which gives that sensation. When PDL is not there, that sensation is not there. So it is from the trigeminal nerve. Okay, maxillary and mandibular divisions of trigeminal. And coming on to the age changes, you can easily remember as the cell number and cell activity, as any old age, when old age strikes, it decreases. Okay. So the activity of the PDL tissues also, it decreases. Okay. And then we'll move on to the next cementum topic. In the cementum, you need to know again about what is cementum and the composition, the various, junctions, cemento-enamel junction, cemento-dentinal junction, and majorly the types of cementum. Okay, that is what we'll have to know about in cementum. So, and also age changes in cementum. So the cementum, it is when PDL was a highly cellular and highly vascular component of the periodontium, the cementum is a avascular component, mesenchymal tissue. Okay, it's a calcified avascular tissue that surrounds the root and a root of the tooth. And there is some, it is present in some amount of thickness, and that thickness, it varies from one portion of the root to the other, and it is seen to be it is more in the apical portion, okay, around 200 micrometers, whereas in the cervical it is only 16 to 60 micrometers. Okay, and the cementum is permeable also. That means it allows the diffusion or transfusion of fluids or whatever, the bacterial toxins and everything into it. Okay, so it's permeable. And regarding composition, it has got, so we have seen it's calcified. So it has got some inorganic components also, but has got some organic components also. So the organic components is 50 to 55%, and mostly whenever there is an organic component, it is a collagen only. Okay, type 1 collagen fibers, and also this proteoglycans and glycoproteins and everything. And then the inorganic component, you have the calcium, phosphate, magnesium, and hydroxyapatite crystals and everything present. And when we come to the classification, it is mainly classified on the presence and absence of fibers and the presence and absence of cells in it. Okay. So on the basis of presence and absence of, cells, it is acellular and cellular. Okay. And then on the basis of presence of extrinsic, okay, you have both intrinsic fibers and extrinsic fibers. Intrinsic fibers are the ones that are produced from the cementoblast itself, okay, or the cement from the cementocytes. The cementum forming cells produce some amount of intrinsic fibers, whereas extrinsic fibers are Sharpie's fibers. Okay, the periodontal ligament fibers, because cementum has got the Sharpie's fibers or the periodontal ligament fibers attached to it, no? So that portion of cementum has got extrinsic fibers. So it is based on the presence or absence of extrinsic fibers. Also, we classify the cementum. So on the basis of that, we can classify it into these 4 types. Okay, acellular, afibrillar cementum. As the name itself suggests, it is a portion where there is no cell and where there is no fiber at all. Okay, there is no fiber. Okay, that both the intrinsic and extrinsic, both is not there. And that is seen in the most coronal cementum. Okay, the most top portion. Okay, whereas next one is the acellular extrinsic fiber cementum, where there is no cell, but there is presence of extrinsic fibers. Okay, so that is found in the cervical third of the roots. After the most coronal portion, the next portion. And then you have the cellular mixed stratified cementum, where you can see the both the cells as well as extrinsic, intrinsic fibers, everything is there. Okay, so that is in the apical area, the bottom portion. And then the cellular intrinsic fiber cementum is the one where the extrinsic Sharpie's fibers are not there, but then there is intrinsic, its own fibers it produces. And then there are cells also to produce it. So cellular cementum. So that fills up the resorption lacunae. That is whenever the cementum, it has got a highly a blessing that it continuously, just like the bone, but not as much as the bone. But it has this property of resorption takes place, but then it has this ability to repair to some extent. So in the resorption lacunae, you can see this. Okay. So the next, you will have to know about the various junctions, because, cementum confluence with the other parts of the tooth to form various junctions. So we have the cemento-enamel junction, where cementum and enamel join together, and also cemento-dentinal junction, where the cementum, which lines the root, connects with the dentin on the internal cavity of the root. Okay. So the cemento-enamel junction, the thing which you need to know is the different types by which, there are different patterns of overlapping that is being seen. So you should know which is the most commonest seen one, where the cementum overlaps enamel. This is the most commonest one, which is seen in 60% of the cases. Okay, the enamel is there, and then the cementum overlapping enamel. And the next one is pattern 2, where end-to-end approximation in 30% of the cases. Okay, and the other 2, you just know that there are other 2, but then you need not learn. There is a type where it doesn't connect at all. And also there is a type where enamel overlaps the cementum, which is least commonly seen. But the most commonly seen, you have to know that where the cementum is overlapping enamel. And then the dentinal, cemento-dentinal junction, this is the cementum. Here, this is the cementum. And here, this is the dentin, internal root canal, the dentinal portion. And the point of confluence of this is called as a cemento-dentinal junction. And this is a landmark of significance, especially in the endodontic treatments. And then you will have to know about the incremental lines of Saltaire and also this immediate cementum. Don't confuse both of this. When sometimes the definition of both can be given, and what can be asked. So how I remember it is, I've already told you, cementum has got this ability to repair on its own. So it will undergo resorption and then it will reduce to and try to repair that area where resorption takes place. As well as also when the cementum formation happens, there is some rest period that happens in between, which produces these lines which run parallel to the root in the cementum. So these lines of rest, which are rest periods, which represent the rest periods, which run parallel to the long axis of the root, are called as the incremental lines of Salter. How I remember is this incremental. There is a incremental is rest. That RE, it's a little more pronounced, no? So that's how I remember it. And incremental lines of Salter, it is with the rest. Okay, rest periods. Whereas this intermediate cementum is a less radiodense or a diffuse layer between the cement and the dent. Okay, and it is believed to be, that portion where the remnants of this epithelial root sheath remains, and it is not seen in all the, all along the cemental portion, but in certain areas. So this is what is called as intermediate cementum. The other name for it is hyaline layer of Hopewell-Smith. And then the function of the cementum, it has this fibers attached to it. So it also helps in anchorage and support, and also helps in the repair of any resorption. So that is another important feature. And with regard to age changes, we see in the PDL, the cellular activity, number of cells, everything decreases with age. Whereas in cementum, the width or the thickness, it increases with it. There is more of deposition happening. So as a result, the thickness കൂടുമ്പോൾ what happens? Permeability കുറയും. കുറെ thicker ആവുമ്പം the transfusion, diffusion or whatever it is doesn't happen much. So the width and the thickness, it increases as deposition കൂടി വന്ന് thickness will increase, but then the permeability decreases. And these are the conditions of variations which is seen in with relation to cementum. That is hypercementosis. It is a condition where there is excessive cemental deposition taking place as a result of some pathology like periapical lesion or something like that, which low-grade periapical lesion, and also generalized hypercementosis is seen in a disease called as Paget's disease, which you have to remember, Paget's disease. Okay. And then also in cases where there is excessive force, orthodontic forces and all, you can see this hypercementosis. Hypertrophy or hyperplasia are variants of this hypercementosis, where trophy is actually, hypertrophy is the increase in size of the cells, where the plasia is the number of cells. Anyways, the radiographic appearance will be that cemental portion, there will be excessive deposition of the cementum. And then the cementicles also you need to know, which we have, I think, in the periodontal ligament, they are the calcified cemental masses, which is seen in the periodontal ligament. Okay. And then another feature in response to cementum is ankylosis. Ankylosis is a condition where, the cementum fuse with that of the bone, where the PDL is absent. So, same result, because of the same thing, that PDL is not there, the proprioception or the sensory thing is absent there, and the tooth, the continuous eruption doesn't happen there. So the tooth will be in the infraocclusion, and clinically you can notice it as an infraocclusion, as well as there is on tapping, it gives off a different metallic sound, okay, on tapping. So that is how clinically you appreciate it. And finally, with the cemental repair, there are two things which you need to know. That is, there is something called as, I told you, there is resorption that is happening with cementum. So, and they always tend to repair that resorption also, which is a good thing. But there is something called anatomic repair, and there is something called functional repair. Anatomic repair is the one in which the exact outline is repaired. Okay, wherever the resorption has happened, the exact outline is repaired back. Whereas the functional repair, there is a resorption, a bay-like concavity that is there. That I have a picture. Yeah, this is the resorption of area where resorption of cementum has taken place. This, it will try to repair and some amount will get repaired, but then there will be that concavity that will be present. So what happens? The bone, it projects into the concavity and try to fill up that space. So this is a functional repair. Okay. So then finally, there is a point like cementum is sufficiently permeable, which I have already told you, and this is because of this permeability that it allows a bacterial invasion, as well as the caries, hypersensitivity, and everything is attributed to this permeability of cementum. Okay, that is a point that you have to note down. And then finally, we are coming on to the alveolar bone, which is very very short topic. There's only some important things that you need to know. You know what is alveolar process, isn't it? It is that part of maxilla and the mandible where the tooth is, rest or the tooth remains in the socket, right? So only that particular portion of the bone which holds the tooth is called as the alveolar process. And this, due to the same reason, when we lose the tooth, that alveolar process, it resorbs. Okay. And the rest portion of the maxilla and mandible, other than the alveolar process, it forms a basal bone. And you should know, so this is the longitudinal cross section of the tooth with the alveolar, the entire bone with the basal bone and this alveolar bone or alveolar process, okay, where the tooth is harbored. So here, there is a cortical plate, hard cortical plate, and inside you have the porous cancellous bone. So there is an outer cortical bone and inner, cancellous bone that is present, okay, in relation to the alveolar process. That is very important. So, and this is the interdental septum that is between the two teeth, the bone that is present. It is called as an interdental septum, which is more of the cancellous bone. You can appreciate it here. Very porous, right? Because all of the innovations, blood innovations, everything, is traversed through this. So that is why it is highly porous and spongy. And this one, this is a socket wall, right? Where the tooth was there. Okay. So this portion of the alveolar bone, which lines the socket, okay, and has got minute openings. Okay, this is called as the cibriform plate. And this has got multiple names actually, depending on, the various features. It is all the same actually. Alveolar bone proper, bundle bone, cibriform plate, lamina dura, everything is the same. Okay. This socket, it is all referred to the socket wall, okay, in the alveolar bone. So that is the inner socket wall. Okay, this is a thin compact bone actually with minute openings. Why the minute openings? Because you have the Sharpie's fiber attachment to it. And that is why, that is a bundle fibers, no? So that is why it is called as a bundle bone. Okay. And then it is called as alveolar bone proper because it is that portion of the alveolar process which actually holds the tooth. So it is alveolar bone proper. And then the name cibriform plate is also given because, it has got series of openings for the nerve endings. Okay. So that is also nerve as well as blood vessels and all that. So that is why it is given as a cibriform plate. And in the radiographically, this will seen as a radio denser line, and that is because of this same attachments, fiber attachment. So it is called as a lamina dura radiographically. So in this picture, it can be that openings and all are very clearly visible. So this is a thin compact bone with minute openings, which are called as bundle bone, cibriform plate, radiographically lamina dura. All these names are the same actually, given to one specific part of alveolar bone, which actually holds the tooth, the inner socket wall. Okay. And then another thing is the periosteum. This alveolar bone, alveolar process has this periosteum and endosteum. Periosteum is the outer tissue. It is outer tissue that covers the bone, while endosteum is that portion, that tissue that lines the inner bone cavity. This is the bone cavity, this inner lining. So the tooth socket wall, isn't it? The one here. Here you have the endosteum because it's a bone cavity. So there we have the endosteum here. Whereas when you reflect the flap, what we have, the outer covering, it is the periosteum. Okay. Both of it has got osteogenic potential, has the ability to form bone cells. Okay. And there are some anatomic variations that you need to know in relation to alveolar bone, which are what happens? Normally, what happens? Normally, you have the tooth, which is hold in the alveolar bone socket, and then above which you have the periosteum, and then you have the gingiva covering it, right? So there are conditions where this might not be seen. Okay, so that is in case of dehiscence and fenestration. So fenestration means it is how to remember it easily. Fenestration means it's foramen-like. It is a bony window which is seen. Okay, on the where the root of the tooth is denuded, that bone is being denuded. It's not present, and there is a bony window which exposes the root of the tooth. And the dehiscence, but in the fenestration, the marginal bone, it is intact. It is like a bony window, which is foramen-like. Where in dehiscence, the difference is there also actually it is devoid of the bone, but the marginal bone is also not present there. So this is when the flap is, the gingiva and all will be there, but then this bone is lost in this both region. Okay, this is the example for fenestration, and this is the example, the picture for dehiscence. So here you can see this is a bony window-like opening where the marginal bone is intact, right? But here, this is fenestration, this is dehiscence, where the marginal bone itself has been denuded of the root surface. So don't get confused what is what. Remember it like fenestration, F foramen-like a minute opening, where the marginal bone is intact. While dehiscence, it is denuded areas. Okay. Dehiscence, denuded. Areas extended. Okay. And then with regard to alveolar bone, the properties, just like your cementum, you have and mineral components and organic and inorganic components. But this has more of inorganic component, minerals, and it's in a state of constant flux or change. Bone remodeling happens continuously throughout. So this is the final last portion. I want you all to be very attentive because it's slightly difficult to be understood. So I'll explain it the most brief way possible. So this is when we talk about the properties of alveolar bone, we told it is a revolving state or in a state of flux. Continuously it changes. Okay, there is bone formation, bone deposition. It happens continuously. So there are cells associated with it that helps in this process, or that is actually playing the key role in this process of formation as well as bone resorption. So what happens? Osteoblast and osteoclast. These are the two cells. Osteoblast are bone-forming cells. Osteoclast are bone-resorbing cells, as you all know. So they are the cells that plays a key role in this remodeling. Okay. So how do they function? We have to know a little bit about this bone remodeling. So that is, what you need to know is both of the cells actually are interdependent. It's not that they function as two separate entities. The most interesting thing is that they need one another for each of it to function. Okay. They are interdependent on each other in bone formation as well as bone resorption. So what happens is when there is an inflammatory component, when there is a bacterial attack, or the host starts responding with its defense cells, and a lot of inflammatory mediators will be produced on the process. So you have this osteoblast and osteoclast precursor cells always there in the PDL as well as in the bone and all that. So what happens is when this inflammatory mediators are released, in presence of certain mediators like interleukin, that we'll see in the host response again, but again, just to make it again retained in your mind, there are some mediators, mainly three: interleukin 1 beta, interleukin 6, and then tumor necrosis factor alpha. So these are the three bone resorbing mediators that play a crucial role in bone resorption. So this, in presence of these mediators, this osteoclast precursor cells, they get activated. Okay. And what happens is that, it is completely based on Wrangle OPG mechanism. This is the key system which controls the entire bone remodeling, formation, and resorption process. So you have this osteoblast, you have this osteoclast. And Wrangle and Rank are receptor molecules which are present on each of it. How do you remember it is like? I remember it like you have osteoclast where a rank is given. Okay, because they help in resorption, no? So a rank is given for them. And osteoblast but have a positive role in bone formation, right? So an additional L is given, rank L. Okay. So it is this rank L is a receptor which is found on osteoblast, and rank is a receptor that is found on osteoclast cell. So when so these are present there always. Okay. So when an inflammation happens, when inflammatory component takes place, these mediators are released. So they stimulate what? This interaction of wrangle and rank. And then once this wrangle interacts with the rank receptor, this osteoclast cells, they get activated and then they produce osteoclast cells get produced and then they get activated and then they cause bone resorption. So basically what happens, wrangle on this osteoblast combines with the, connect with the rank on the osteoclast in presence of certain inflammatory mediators, which result in differentiation and maturation of osteoclast. And then finally it results in bone resorption. So that is what happens. So osteoclast cannot function on its own. It needs this wrangle from the osteoblast to get activated and cause resorption to happen. That is what I mean, okay, by the interdependency. Now we will see how osteoclast is important for the bone formation in bone remodeling. So that is, once this resorption happens, bone resorption happens, you know there is organic components in the bone, organic part of the bone, no? It has BMPs, that is bone morphogenic proteins and certain other proteins, which will be released. And then because once resorption happens, this organic matrix, it degrades, degenerates, releasing the proteins out. So these proteins will go and stimulate the osteoblast and signals them, okay, for the bone formation. So it is like a cycle. So that is how wonderfully they are interconnected. And so they, this interdependency on each other is called as a coupling. Okay, so that is what is called as a coupling. So, and another factor which you need to know is the OPG. OPG is osteopontegrin. This is another ligand which is it is called as a decoy receptor because it is similar to that of the rank and in its structure and things. So that what happens is when this OPG, they interact with the rank-wrangle interaction and then prevents their interaction. So inhibiting their interaction so that this bone resorption, it inhibit the bone resorption. OPG, when it comes in excess, it actually inhibit the bone resorption. So that is why this statement is important. In areas where there is active periodontal breakdown, this OPG levels will be low because OPG levels, if it is higher, they will inhibit the osteoclast formation itself and bone resorption itself will be inhibited. But when the OPG levels are lower in active periodontal sites, whereas rankle and rank levels will be on the higher side. So I want you to know about that particular portion also. We'll again discuss this in the host response time. And when we talk about the host response in the subsequent session. But I hope this is clear. I'll explain once more if it is not clear. That is, this osteoblast, you have two cells, osteoblast for formation and osteoclast for resorption. And on the osteoblast, you have rank L attached to it, rank L receptor. And on the osteoclast, you have rank attached to it. And both of it, they interact together in presence of inflammatory mediators. And only if both of it interacts that this osteoclast will be formed and will get activated to cause bone resorption. So this OPG, what happens? It comes and interfere with this interaction, inhibiting the osteoclast formation, so prevents the bone resorption. So this is what it is to summarize. Okay. So that is all about the entire and other supporting tissues, as PDL, cementum, and bone. And I want all of you, to now, at least if today you cannot, maybe tomorrow, if you haven't solved Dental Pulse, try solving it without reading solutions. I'm pretty sure if you were attentive, you will be able to solve most of the questions. Okay, or all of the questions. I've covered it. So I hope the session was useful for you all. Give me the feedbacks also, and wherever I need to be improved. Okay, thank you. In case of any doubt, if you want to be asked now, you can, or you can text me personally or in the group as well. Okay. Okay, so then I think we'll wind up the session. See you for the next session. Okay, bye.